That was a tough act to follow, but we will do our best. We are a smaller panel, but we are a mighty panel, so hopefully we will engage you in the next 45 minutes. We're going to go to the other end of various spectra. The last panel was talking really about government policy and how to take care of everybody top down. It was also talking primarily about India, healthcare for India. We're going to go to the other end of the spectrum because we're going to go to the entrepreneurship side and ask, how do you actually implement innovation at the ground level, whether it is or is not in line with the government policy at the time you are innovating. And we're also going to be talking about healthcare, not necessarily in India, but powered by India for the rest of the world. Because a number of companies have emerged. We're joined by one of those entrepreneurs today who have taken innovation from India and come to the United States to build a business. In many ways, the US is the prize market today because, let's face it, in the US, we overspend dramatically for healthcare, and we have a lot of inefficiencies, which we'll talk about. So we're thrilled to have operators from the healthcare industry in the United States with us. And I'm going to be playing the role of moderator, but also panelist, based on my experience, which I'll talk about in a minute. But we'll go from your right to your left, and just instead of just saying hello and introducing ourselves, I'll give each of us a leading question so you can understand the journey each of us was on in this context of using entrepreneurship to drive change. So Bridge, you have started at square one, or zero, as Peter Thiel would say, going from 0 to 1, more than once. As explained in your bio, you were the CTO at Ola, among many other important and impressive roles. And then you put all that aside to start a company focused on physical therapy. Can you talk about the delusion that came to you as an entrepreneur that said, I know what I'll do, I'll start something from nothing? How did you get this idea, and how did it develop? And maybe if you could comment as well on the difference between a direct-to-consumer business, which you did previously, and a business-to-business affair that you have now.
Thanks, Carl. Good evening, everyone, and thanks, 8 Roads, for having me on this panel. As you said, I'm a second-time entrepreneur, right? And my first company was an accidental startup. I was doing something on Twitter. People started following me, and I said, okay, cool, let's go and make an app out of this, right? The second time, you would like to think that you're a little more thoughtful. Prem is here, so my board is here. I need to say that I was a little more thoughtful. So if I say my first company was constraint forward, I knew some technologies. I know I was doing business in India. I knew I could not sell to the businesses, right? So I'll make a consumer app and just see what happens. Didn't think how it would monetize, how it would scale, how it would build a team. Obviously, the first one was rewarding. It had its own benefit, but it left a taste of more, right? I think I could have done more. And when I started my second company, I didn't know what I was doing. I was not thinking of physical therapy, nor I was thinking of US healthcare. US healthcare was the furthest thing in my mind right at that time. But a few tenets which I thought I'll take along with me, the learning from the first company to the second one. First is, I wanted to make sure that I'm part of a big market and a growing market. Public transport, my previous startup, was a big market, but a declining market, right? If you remove states like Singapore, Seattle, or London, public transport ridership is declining in all these states. So when you're building for those opportunities, you don't create value for yourself and for investors, right? So US healthcare, for a software professional, I'm not talking about services, but US healthcare for a software professional is the biggest prize in the world. So that made sense. Second is, I wanted to make sure that I'm a deeper part of the value chain, right? When I was doing Riddler, we were selling bus tickets, which cost 20 rupees, right? And my margin was 20 paise within that. It's very, very difficult to make money or a sustainable business out of that. Whereas when I was doing Ola, we were taking 20% of the commission, right? That's a sizable business. So when I saw the opportunity, I wanted to ensure that I'm a deeper part of the value chain, right? So when we thought of Spry, we're not doing the administrative work, but we're also playing a role in the delivery of healthcare, the remote therapeutic monitoring. So those are the third thing. And the third thing, I think it aligns with the view of the world, right? I think some of the panelists discussed in the previous call. Healthcare needs to move from sick care to preventive care. And the technology that we are building can actually help mitigate that. Right? So these are the three things that I started. These are the three tenets of how I want to start my next business. And we started looking around US healthcare stands out, right? 8% of the GDP is being spent on it, huge amount of administrative cost. But when you see, you cannot address it all at once, right? You have to break it down. It's like, I've heard that saying, it's not a $4 trillion industry, it's $104 billion industry, a $1,004 billion industry is how we look at US healthcare, right? And if you want to play a deeper role in the value chain, you have to find a specialization. So when we looked around, MSK, musculoskeletal, which we address, is the top 5 non-communicable diseases, right? And it's growing. And anecdotally, you see that people in their 30s, people in their 20s are complaining of back pain. People are living longer, but not necessarily healthily, right? So we believe that the market will grow. So I think these are some of the tenets that we took along. And that's how we decided that we want to focus on musculoskeletal, right? So also comes down to how I am as an entrepreneur. I don't come from the healthcare background. I realize I'm the only panelist who's not a doctor or a PhD or from the healthcare background. But we're a problem solver, right? And I thought we brought an outside, fresh perspective, outside-in perspective of how to tackle healthcare. So then we realized that we started doing some work in India. We started doing business in India as well. We started working for the physical therapy clinics in India. But we realized that the problem that software solves for them is not going to create the value which software could solve for in America, right? And one of my learnings in Ola was that attack the hard problems earlier, right? When we launched Ola in London, we realized that the average ticket size of auto rickshaw was equal to the tip value that he was getting there. So why not go to attack the biggest prize in the world, right? Healthcare. So I think a lot of delusional thoughts, but I'm very glad we made that decision because, yeah, it is a difficult market to crack, but once you crack it, once you open it, it opens a lot of avenues. So a lot of things that the previous panelists talk about, data automation, data. We are bringing all those learnings. Hopefully when India is ready for that, it will bring a lot of those learnings up front. Right? So I think that is how we started Surai, and that's the story behind it.
Thank you for that, and we'll ask you more about your company a little later. One thing everyone observes when they get to the US market is how hard it is to penetrate different sectors. I've heard people say, don't go direct to consumer, that's really difficult. And then at the same time, don't go to providers because, the sales cycle is too long. And while we're talking about it, don't go to employers, they're too finicky. So they pretty much eliminate every possible opportunity with their list of things you shouldn't do. So Anna comes to us having done most of those things. You started at McKinsey, you went into pharma, you then went into the payer side at a Blue Cross plan in Florida, very large one. And then you became an analyst on Wall Street of many different types of company who were trying to go from 0 to 1 to build a business in this market. Can you comment on your journey and then maybe comment along the way on your observations about why it is so difficult to change things in the US healthcare system?
Hey, thanks, Carl, and thanks to Prem and everybody at Atroz for having me. So I have about 25 years in healthcare. I've moved around in a couple of parts of healthcare, strategy, innovation, and then very deep in finance. But my passion has always been in innovation. I have a PhD, I have a master's and PhD in bioengineering. Prem and I actually were in the same undergrad institution as well. And after I left McKinsey, I went to Pfizer, and I worked for about a couple of years in more on the planning side. So it was all strategic planning in the discovery, pharmaceutical sciences, drug safety, and then in the latter 3 to 4 years, I headed up planning for drug development worldwide at Pfizer. So, that was kind of my journey through the R&D side of Pfizer on planning. I then did make the pivot, and I actually made the pivot into payer provider into Aetna first. And at that point, that was like in 2006 to 2008. And so health tech in the payer universe, it was very nascent. And I have to give Aetna a lot of credit for, really some thought-leading work. And the C-suite that I worked with, Ron Williams, Mark Bertolini, who became, CEO after I left, just spearheading some of the most innovative technology-enabled views on how to improve cost of care, how to bend trend. And I led and spearheaded the total cost of care tech-enabled strategy for Aetna, and also spearheaded a bunch of strategic alliances, all very around innovation with the EMR companies, a bunch of EMR companies, Microsoft, IBM, Amazon, and that was quite thought-leading at the time. My Florida Blue Cross journey, and that was, kind of in the C-suite in a very large blue plan, was more recent. It was after I left Wall Street. I was heading up strategy and innovation. So I did the entire enterprise strategic planning for Florida Blue, but I also was the head of innovation for Florida Blue and the CEO of innovation for Guidewell, and I headed up the early stage, the venture fund, and kind of mentoring the early stage companies at Florida Blue. So I had a kind of a view of each of the pieces of healthcare, but I hadn't done anything on the hospital side. But then I did a very long tour of duty, if you will, as an analyst on Wall Street in the two firms, Bernstein and Leerink. And I think what you really get, and what I feel I got as an analyst, was to get a bird's eye view of healthcare. You're doing it like 100, 120 hours a week, but you're really looking at the ecosystem as a whole, and you're interacting with the C-suite of every company. And I covered payers, providers, digital health, all of it on the non-pharma side. And so I feel like I had the ability to look at, in a value-based care context, how do you align the business models? If there is an innovative idea, how do you not just look at product market fit, but how do you align the business interests across these various constituents? I have like detailed knowledge of all the P&Ls and cash flows and all of that. So coming up with pricing models, so that's where my focus has been recently, and why I gravitated toward early stage, product market fit, go to market, because the relationship capital that you build as an analyst, and then my other parts, in corporate were quite heavy. To your second question, Carl, why is it so hard to make a change in healthcare? I do feel we've come a long way. When I first started in healthcare, and when I was out in Aetna, I would have not believed that it would be anything beyond just acute care and a fee-for-service model. But I think we have come a long way. I think it's been catalyzed by the government and by the private sector. I think largely by employers, the government, and the health plans, because they're on one side of the ledger, if you will. And now with value-based care, you are transferring that risk and the upside to particularly the primary care doc, which is the linchpin in the whole system, and now health systems to some degree, especially if they're not capacity constrained. And bringing in pharma to a degree to where wherever they're part of the equation. I think COVID has been another massive catalyst, I'd say, in terms of adoption. I don't want to talk. We'll come to that, but yeah.
Well, thank you. As you can tell, Anna has a tremendous perspective on what it takes to be successful in the U.S. healthcare system, both from big companies but also early stage. So we'll come back to that as we try to crack the code on how to be successful as an entrepreneur in the U.S. market. By way of my own introduction, I'll just ask myself, Carl, tell me about Athena and the Athena story as a way to explain my perspective and my perspective as an investor. So briefly, we started Athena Health in a basement near Boston in 1997. We originally thought that our big innovation would be to professionalize the medical side of the industry by becoming managers of medical practices. There was a trend called physician practice management as an industry. And we focused on OBGYN initially because that was the most expensive and variable thing that happens in healthcare, especially if you add up all of the hospital costs. So we went to work on that, and we were a bunch of 20-year-olds telling doctors what to do, which was a weird position to put ourselves in. And what we found quickly was we had to set aside our big ideas about changing the way payments happen in healthcare to get incentives for saving money and improving quality, because we couldn't figure out how to run records. So 2 years in, we had learned that our original business model was not likely to work well or scale because it was very fragmented. We were people sort of managing doctors and doctors didn't really need managers. They needed infrastructure that worked well. And so we did one of the most important things in entrepreneurship, which is we recognized that what we were doing wasn't going to work, and we pivoted. And so often entrepreneurs say, I had this vision from day one, and then I went and did it. But what they often skip over is all of the times they ran into trouble and had to change. So what we did was we abandoned our plans to run medical groups and said, well, we're going to use this system we built to serve all doctors so they have reliable infrastructure for running their day-to-day medical practices. And that turned out to be a much better idea. And Athena Health started to grow very quickly. Because basically we understood that doctors wanted to be doctors taking care of patients. They didn't want to have to deal with insurance rules or formatting their medical claims or trying to figure out which patients did or didn't have coverage. They wanted to just focus on medicine and let others take care of the rest. So we built a business to do that, and then it quickly scaled. We went public 10 years after we were founded. It was the first internet-related business to go public, and so the healthcare people were pretty confused when the stock doubled on the first day because Wall Street understood that recurring revenue models powered by scalable software as a service, was quite compelling. So long story short, Athena did very well as a public company. I was a CFO there for 12 and a half years, and it sort of went on to become one of the systems that doctors turn to when they need that type of support. I think the lesson in there for us was pivoting, as I mentioned, but also really focusing on the needs of the customer. Later, I switched into being an investor, where I am now at F Prime, which is affiliated with 8 Roads, looking for the next Athena, trying to find companies, and I'll talk about some of those themes a little later, but companies that can really innovate in similar ways. So that kind of goes back to what I mentioned earlier for Breege, which is like the challenge of being an entrepreneur is to try to change the world or reshape the world in a profitable and scalable way. And someone on the earlier panel mentioned that if things were easy, they would already have been done by now. The world is organized the way it currently is, and lots of people are getting benefit from that. So when you have an innovation, you have to convince the world to change how it operates. So, Breege, as you think about physical therapy in your business, what did you identify as broken, and how are you going about fixing it as a case study in innovation in the US economy?
A few things, right? And for that, you have to look at the progression of software in healthcare in the US, right? So for me, if I look at it, what was the last decade about, right? It was Obamacare, digitization, right? So you see that 98% of the healthcare records today are digitized in the US, but that was not the case 10, 15 years back, right? But as you also mentioned, treating a patient there's very little, it's not only about digitization, right? It's the entire workflow, from scheduling to insurance eligibility to actually applying for the claim, and also eventually making sure that the patient has the achieved desired outcome, right? So all the work that was done in the last decade, and obviously because of the incentives from Obamacare also, was around digitization of records. But everything before and after that was broken, right? So if I have I know a lot of panelists here from India. So if I think of where healthcare in US today is or was a few years back, it's very similar to where fintech was in India, right? We had the rails for UPI, but the adoption had not yet happened. So now we have digitization, which has happened at EMR. We have interoperability, which is happening. There is tech adoption or cloud adoption, which has happened because of COVID, specifically in the physical therapy world. So I saw that these were some of the tailwinds that helped us to focus on physical therapy. What are the problems specific to physical therapy that I saw? 2 or 3 which stood out. First of all, that most patients were not completing the plan of care, right? It's impossible for a patient to come 10, 12, 14 visits to the clinic, avoiding everything and making sure that they complete the plan of care. Second is the administrative cost of managing a patient in physical therapy was very high because of the need for referral from a primary care physician, the need from an orthopedic, etc. And the third, this is the physical therapists in my team say that we are the lowest in the totem pole, right? So the average reimbursement values for all of these guys are the lowest. right? So a gynec would get a higher amount, a cardiologist would get a higher amount per visit, but a physical therapist gets a slightly low amount. So the need for automation in all these things, right? So how do doctors make business, right? They want more patients, you want to maximize the lifetime value of the patient, and you want the least possible cost. So right now, what we focused on, how can we maximize the value of the patient? If patients achieve the plan of care, if patients complete the plan of care, then they would obviously avoid downstream surgical costs. So that's where we came in. The other is with all the automation that we're doing, right from appointment till the time you get your money from the insurance company, if you automate that, that reduces the administrative cost, right? So I saw that a lot of the work which was done in the prior decade was not focusing on the end-to-end workflow, right? It was only focusing on digitization. But that laid the foundation for companies like us to come and build on top of that, right? So we're not solving the same problem in a better way. We're just solving a different problem as compared to the common. So that's what we saw, and that's what we're capitalizing on right now.
Thank you for that. And in the background is this question of, why does it make sense for an entrepreneur from India to innovate on the other side of the world? We mentioned the prize of the US healthcare market, but clearly there are some additional challenges to go from starting in India to operating and growing in the US market. But there are also some advantages. And Anna, you've seen all of the sort of success and failure modes in many different industries, and you're familiar with both the US market, obviously, first and foremost, but also some of the challenges and opportunities of Indian companies coming to the US. So from your perspective, as you think about, if you're advising someone on coming to the US market, what should they know about what's broken, the opportunity to improve it, and maybe the trade-offs as an Indian company coming to the US?
Yeah, so it's a $4+ trillion economy, and it's 18% of the GDP right now. There's been a big focus, finally, but maybe for over a decade, especially post-legislation of Obamacare, to moderate medical costs, but then to also, it's kind of quadruple aim, to improve access, to improve member experience and provider experience. And there is actually a lot of payout from CMS and then increasingly the employers as well, from a premium per member. So there's value in that, and then quality and outcome. So that's kind of the broader context of the whole thing. Some of the themes, I think, that are opportunities for SaaS founders and innovators, and some of them are a little more durable and have been there longer term. Some are more recent. One which I heard a lot being spoken about in the Healthcare for All session, and that's more in the Indian context, is about population health. And I think it's really taken hold. The whole notion of chronic care management and keeping people out of the hospital. And that requires stratifying the risk, making sure that you know exactly where you're going to put in high-touch care, and maybe where you put in digital therapeutics. And there's a whole data and analytics platform that needs to be built, that a lot of the plans and the providers are looking at outsourcing. So that's kind of one big theme. The second is whole person care. And I didn't hear that much about it, but I'm sure it's a part of what you're thinking about in India. But certainly in the US, it's front and foremost. Integrating medical care with behavioral, so the mind-body connection, dental, so mouth-body connection, but now increasingly social determinants of health. That's kind of the buzzword, food, housing, and transportation. And so you're looking at by payer mix, Medicaid for the lower income, Medicare, the seniors over 65, employer-sponsored. How do you integrate all of these various touch points of care and have a holistic picture? And that's not just for providers, but for members themselves. How do you create platforms that help them navigate their care across these various modalities? The third, I think, which is relevant to Bridge, and he and I do work together on Spry, is about the home as a site of service. That's like a massive, massive theme. It's not just on chronic care. It's now heavily in post-acute, where there's been a shakeout of post-acute capacity. 50%, literally, of skilled nursing facilities, have been shaken out or closed down, or there's been a reduction in staff. And now even more so hospital at home. So there is an opportunity to create platforms for that, and Bridge is doing it for, for virtual PT, which is a huge piece of post-acute care at home. But it's all across virtual command centers and the clinical and radiology diagnostics and monitoring, having middleware with food and transportation providers and all of that. So there's a huge, and there's a underpinning data and analytics platform, claims and clinical data, and all of that. So there's there's so many opportunities. And as you think about value-based care and all of it's a third-party paid system with a very patchwork set of members. So you've got the payer, which is all of the different payer mix, the provider, and then the member, and how do you create monitor value creation and then share the spoils across. And that requires a lot of attribution and metrics and tracking. And then there's the the final opportunity, I would say, and a big one is the administrative waste in the system, which is somewhere between, they say, it's now they're talking about numbers like 300 to 500 billion. So it's it's about credentialing the providers, it's about patient eligibility, and then the whole payment system, which is so inefficient, with this kind of cat and mouse game, as you know better than anybody, Carl, between the providers and the payers. And so, what can the India advantage be? And I think, there's a lot. Obviously, there are the obvious ones, lower the cost, availability of tech talent, surely. But I find that as I think there's, when you take an offering to, an enterprise sales, and these are non-trivial sales. You're talking about, firstly, large enterprises. There is a very complex movement of money, and that can be very customized depending upon your use case. You really need to have clinical, evidence-based ROI and studies. And my view is, rather than have nothing, I would rather do it with onesie-twosies. If they're onesie-twosie, let's say PT practices, or I'm doing it with an academic medical center in India. I think that's perfectly legitimate, good data to put in front of the right stakeholders. Versus I've never tried this before, and I think that would go a long way. So there's opportunity to do that. I think as we go into AI, more and more, it's not just Gen AI, but just predictive data and analytics, and the ability to train these models is much harder, I think, in the US, because these different, and I'm not saying it may be as easy in India either, but certainly in the US, there is a lot of, very protective mentality around data sharing. And if you could do some of that, because there's a lot of incidence and prevalence of disease, certain disease conditions particularly, and you can train these models, both clinically as well as administratively, I think all that would go a long way. Challenges, regulatory, you need to be high trust certified. You do have to have these clinical evidence-based models. The complexity of the business models is not, there's no standard formula. Each product and offering, you've got to think it through and say, where would this fit in? And how can I maybe use it for access or experience or cost or a mix of both? And all those are complexities. So I think trying to do it without the knowledge and domain expertise would be challenging.
Thank you for that. One aspect of the Athena story involves India, a big part of it actually. So we developed the company in Boston. All of our customers were in the United States. And we had to develop an expertise around medical billing, because the biggest problem our customers had was understanding the Byzantine and multifaceted rules of the insurance companies and enforcing them at the front desk. Many little nuances that had to be understood that could affect whether or not a given provider could provide a service to a particular patient, for example, or whether that patient really had the insurance that they said they had. This required a lot of work to make sure it all would flow smoothly. Well, one thing that happened was we moved from paper to electronic. Back when we ran medical groups, I remember something called the bucket, which was a bin And if a patient was going to be seen in office number 3 tomorrow, but the medical chart was in office 1, you would put the paper record into the bucket because that was going to go in the trunk, or the boot, I should say, of the car of the person who's working in office 3 tomorrow. They can bring the bucket with them, and then you'd have the chart for the patient. We've come a long way. We now have electronic medical records, as was referenced. But during that transition from paper to electronic, we had to, we couldn't just start electronic because payments were checks and they came with a lot of paper. And we were overwhelmed. And so we actually came to India on our own entrepreneurial journey initially for BPO services. We couldn't scale without the manual effort of knowledge workers in India to look at images coming from insurance companies and turn that into data that we could then process. Ironically, the insurance companies were using BPO in India to create the paper, and then the paper was being imaged by us to come back to India to be turned back into data. Even though we came to India for person power, we stayed for technological power because we initially did BPO through third parties, and then we built a subsidiary and we started hiring technologists who are people who could then go to those payers and say, this is ridiculous, let's figure out how to receive this information digitally and avoid all the paper and avoid the manual labor. And so we built a subsidiary in Chennai and hired programmers who got to know and understand all of the claims formats and whatnot, and started building those linkages to make the paper slowly but surely go away. And I think there's something in there about the evolution of India initially as manual labor available at a low cost to high capability because of the tech talent that is here. I think of other companies that have an India backend and a US front end, like Innovacer. Initially, they were using lots of people to gather health data and format it in a way that overnight they could present back to a health system so they could understand what's happening with their patients. And then just like we did, they then moved that to be more and more tech-driven. So it wasn't sweat that was producing the results, but technology. So there's something about that, I think, that is instructive. But there are two sides to that coin. So Breach, I want to come back to you. You started in India and came to the US. I've heard you say, as an offhand remark, you might have been better off not spending the time you did on the market in India before going to the US. So what was the sort of downside in your experience of developing here before going to the US? And do you think that it's still an advantage to have one foot in India, or is that an open question?
Yeah, I think it depends on the context, right? So we were a software platform which was automating work, which was making plan of care easily accessible, right? And if you step back and think, what was the problem it was solving for the doctor, right? One was it was reducing the administrative cost. It was simplifying the payment processing from the payers, right? That's what we do. Both those problems don't exist in India. Administrative cost is not definitely as high as what you see in the US. And then the money directly is exchanged over the counter, right? It's typically, OPD is not even insured for the most part in India, right? So it's normally a cash transaction or a credit card transaction which happens over the counter. And the problems that we were solving of remote therapeutic monitoring, I think it was only affecting the top 1 or 2 people, 1% in India, right? And who had the money to actually go to a PT clinic or call a personal trainer room. So we didn't see that any of those panning out. So when the problem we were solving were not really it was very easy to get adoption because software adoption amongst doctors is not that high in India as much as in the US, right? But very difficult for us to get usage going. So we would have to find a usage battle, right? So you have to pick your battles, right? If you're comfortable fighting a usage battle, you play that in India. If you're comfortable fighting a user acquisition battle, you go to the US, right? In the US, we realized that if we make the right product, which was our skill, which was our strength, we were solving the right problems, then I think it would have been easier for us to get adoption. It would have been easier to get the adoption, the usage going, right? We didn't have to fight a usage battle. The battle that we would have to fight in the US to make the best product out there and have the best GTM engine, right? And I think those are the things we are capable of doing because we're not fighting in headwind of not wanting to use software, or there's no incentive to use software, right? So if you are in the software services space, if you're building automation, even on the AI space, on the data space, I would think that US is the place to go for the one, right? Unfortunate part about building for the US is that if you build for healthcare in the US, you can't build for anywhere in the world. Right? It's so nuanced, so unique that you can't do it. But the good part is so deep, as I said, the numbers are staggering, right? And there'll always be some opportunity to get started. It takes a few months, years, or maybe a year to get started, as even you realize it. While being in the US, it took you 2 years to actually crack open the market, right? So I think every Indian company or an American company will have to go through the iteration to understand the customer. That is a pain. And as a founder, I would actually pack my bags on day one and go there, rather than writing the first line of code, right? So being an engineer first, being a CTO first, it was very easy for me to write the first line of code, get the first product out, and start showing it to people. Rather than I would go to the US on day one. So if I had to go back and do it again, I would be in the US on day one for software, and I would just focus on the US from day one, not do it in India at all.
Quite helpful. As with the previous panel, we'll be running out of time in 10 minutes, so we're going to cover a couple more quick questions and then open up for any of your questions. Anna, I don't want to overlook pharma, where you have experience. Obviously, there's a lot going on with biopharma in India. Can you comment on, in the US market, what you see as potential opportunities in biopharma where Indian entrepreneurs could potentially have an impact?
Yeah, so just looking across the value chain, starting with drug discovery. When I was in Pfizer, and this was supposed to be a big innovation at the time, it was like high throughput screening, to look at the chemistry of the compounds. And even that it's been tremendously laborious. And there's definitely the potential to have a more data-driven, analytic, AI-enabled model on drug discovery. Then on the clinical side, where I spent the bulk of my time on drug development, especially post-COVID, with the decentralized clinical trials, it's about like recruitment. You're doing, virtual trials or a virtual hybrid model, monitoring the endpoints and tracking, and then building, the case for NDA, filing and approval and so on. And then again, then you get into kind of the phase 4 and the, the marketing side, where it's more about, digital marketing and, EMRs, and using that as a way to get to the physician. I do think that, you kind of think of it a little more holistically, obviously, now. It's not just feet on the street and detailing to docs. You do have, you do have the payer as well, and you can try to integrate that, into your digital marketing strategy, thinking about the, the payer landscape and the PBM, pharmacy benefits management landscape. And you can think about also the consolidation that's happened in the, in the physician market, either under the retail umbrella, where the Amazons and the, the CVSs and the Walgreens of the world are buying up or employing docs, and the plans are employing docs, and United Health Group Optum is, one of the most largest, primary care physician, and how did they, how did they do their EMRs, and pharma companies need to think about them as the customer, because it's kind of an integrated conglomerate model. I think I wouldn't kind of look at the hospitals as the way to go. So those would be kind of my 3, takes on it.
Very helpful. For my part, I'll just say that when we invest in the US, the 3 broad themes we've focused on for years are the transition from volume to value, meaning from fee for service to more fixed budgets, and then managing care under that budget. So we call that value. The second theme is automation, which I want to come back to in a second. But automation is going from paper in the bucket to software to data. And then the last theme is access, opening up the walls of the best clinics so that people anywhere can access the best care through digital technologies. We have a number of companies we've invested in that area. But coming back to automation, I'm struck by, as I explained about Athena, we went from paper to leveraging BPO to turn paper into data to software that could produce data that didn't need paper. I think that the last piece of that journey is using the data to create additional insights and value. And now we're in this era of generative AI, of machine learning. It strikes me that just as India was essential to our transition from paper to digital and for creating software, now India could be essential for data-oriented businesses that leverage AI. There are a number of them. I mentioned Innovacer earlier. There are others. It's amazing. The earth is flat. I've had conversations here in Mumbai with people who know everything about how accountable care organizations work in the US, how pre-authorization processes work in the US, and how AI could factor into all of that. So it seems like a real opportunity. We have 5 minutes, so we're going to shift gears and see if there are questions from anyone among us.
Thank you, Carl. Great session. I've actually been a big fan of Athena from 2005 when my program director at Cornell first mentioned it, and it's been great to see liftoff. My question is for Anna, or indeed anyone. It's about the patient as a consumer, right? Consumer healthcare. And off late, we've read quite a bit about digital nudges, digital vaccines, improving health outcomes. Do you see that as a viable proposition, both in terms of clinical outcomes and as a business opportunity?
So are you talking about digital therapeutics in general? Yeah, more broadly. Yes. So I think back in the context of the population health model and chronic care management, it's impossible to be effective or ROI positive if you're randomly putting high touch interventions, even with a nurse practitioner across the board. So a host of digital therapeutics makes sense depending as you stratify the health risk and the opportunity for care management in a population. And that could be, behavioral health, it can be MSK related. My mind is not coming up with others, but there's just so many of them, and there is value. Adoption and engagement has always been, the issue with the members. So it's really important for that offering, the digital offering, to drive, compliance and persistence and all of that. The CMS particularly is putting a lot of emphasis on experience, and I talked about experience, but Medicare, which is which is like 65 million people, half of them are privatized. Medicare Advantage is probably the most targeted and the most profitable market for health plans, and thereby for all the vendors. There is a lot of money allocated to something called star ratings, and that is associated and affiliated and tracked through member experience. Largely, it's 4 times weighted to member experience. So things like digital therapeutics, it incents the vendors or the SaaS founders to make something that's adopted and persistent,
Incidentally, one of the F Prime venture partners is a doctor at Yale named Harlan Krumholtz, and he just published in Health Affairs an article about the importance of aligning the way the FDA and the Centers for Medicare and Medicaid Services and others in government think about software as a medical device, which is a term that's growing usage. And they're starting to align around categorization and ways to codify, including, by the way, the American Medical Association changing the way procedure codes are used so that you could actually code and bill for software as a medical device, whether that's as an assistant to the doctor, an augmentation of the care plan, or as a complete automation where possible. We have time for one more question, if there is one.
Yeah, so you guys spoke a lot about fixing problems that exist, but US has always been a center for innovation. And Prem spoke about it that, post-COVID, we are seeing a fair amount of innovation coming out from India as well. So maybe some thoughts on how innovators in India can be encouraged by what's happening in the US, and how are you stimulating innovation or building fresh IP? What can it do for innovators in India, and how can we get excited? Because I guess there's no path to market, but it's a new product, it's a new delivery, it's something new. So just some thoughts on that.
Maybe we'll use this as an opportunity for a quick, like a really quick lightning round. My quick version would say, I've been impressed with India's ability to leapfrog technologically. If you look at telecom or payments or the description we just heard on the earlier panel about going straight to a cashless, paperless, longitudinal medical record of 1.4 billion people. I mean, that's incredible leapfrogging to avoid all of the stumbling around that we've done in the US for many years. So I think there may be an opportunity to collaborate in an era where data is liquid and secure, but moves around to improve the way healthcare is delivered. That would be my vote on something India and the US could collaborate on. Any further thoughts on that, on opportunities suggested
Yeah, I
by
would
that?
kind of just echo that. I think, we have I mean, some of it is just really, I think someone said in the Healthcare for All section about like, we're not, Americans not using paper in the healthcare system. I don't think that's true, not yet, So the adoption, not just at the member level with digital, data and payments and all, but also at the provider level. There's an enormous amount, and I think Carl would be, has firsthand experience with it. There's an enormous amount of resistance because there are antiquated systems and behaviors, and member and behavior change has been very hard to catalyze. So maybe there's ways for us to learn from, the whole Modi care and all of that on how to change that.
Yeah, as delivery of medicine becomes digital, I think India has an edge, right? Today, using Spry, we're able to monitor a factory worker in Montana for his musculoskeletal care, right? The content for that was shot in Noida. The video for that was done using AI with an American accent. And the reporting, whether their report is valid or not, how much intervention they need, is monitored by physical therapists in India. So right now, we are at a stage where Indian doctors cannot prescribe a plan of care, but Indian coaches, Indian physical therapists can actually monitor the plan of care, is according to adherence or not. So we can create digital medicines, right? I think the question was around digital therapeutics. Can we create digital medicines? There is a lot of that happening for mental health, for physical therapy, for musculoskeletal, right? So that opportunity definitely exists in India. I think the challenge that I as an entrepreneur faced, how to embed that into the current ecosystem, right? So we as Indians understand the administrative layer very well. What we don't understand very well is how to do the GTM for that, right? So that you can scale well. For example, we didn't understand what Medicare Advantage means. Like if I could place that somewhere in Medicare Advantage, that would be brilliant, right? I could see faster adoption. So we need to, while building the products, we also need to understand how the money flows because eventually the money comes from the payers and the employers, right? And embed yourself into that. And that is, we can definitely make the products, definitely on digital medicine, but how to embed yourself into the bigger money game is, I think, what we need to master to actually capitalize on that.
With that, we're out of time. Thank you very much.